Today we're going to talk about symptoms, signs, and abnormal clinical and lab findings. One of the first things we want to distinguish is the difference between a sign and a symptom. A sign is objective evidence, and that is observed by the physician, and a symptom is subjective, and that is reported by the patient. Both, however, are reported. A few reminders about Chapter 18. There's a few situations in which a symptom code is used as a principle, but typically not used as a principle for inpatients. For outpatients, it is not uncommon that a symptom code is the reason for the encounter for different reasons. Sometimes because typically in an outpatient situation, the physician uses several visits before coming to a definitive diagnosis. So you're going to be reporting that symptom until you have a definitive diagnosis. So that's one example. If the sign of the symptom is not integral to whatever condition you're coding, then you can assign a code from Chapter 18 for that sign or symptom. And as I just mentioned, codes for non-specific abnormal findings are rarely used in an inpatient setting, because in the inpatient setting you can code if a physician states suspected urinary tract infection, you can code the urinary tract infection. You don't have to code the symptoms. So it's just a different way that the inpatient and outpatients coding guidelines are organized. This first example, you've got a patient admitted with severe pain, abdominal pain, and she's reported some blood in her stool the last 2 days. And then the physician says it's probably acute gastritis. Now, because she is admitted, she's an inpatient, we can code the acute gastritis with the bleeding. We don't have to code the pain because the pain is integral to the gastritis. So that's an example of uncertain diagnosis in Section 2 of your coding guidelines. When you have terms such as suspected, possible, probable, those type of things, you can code the diagnosis as though it's been confirmed. And there's also combination codes like K29.01 that uses the bleeding as part of the codes. So whenever that combination code includes your symptoms, then you don't need to code that symptom, in this case the bleeding or the pain. In our next example, the patient is admitted with tachycardia. An EKG does not provide any conclusive evidence of the type of tachycardia or what's causing it. Patient is also insulin-dependent diabetic, and the blood sugars are monitored daily. Why do they tell us that? Because in order for a condition to qualify as a secondary diagnosis, we have to know that it was dealt with in the course of the patient's hospitalization. So they're telling us, yes, her blood sugars were monitored daily. So we are going to report her diabetes and the use of insulin as secondary diagnoses. A reminder from Coding Guideline Chapter 4, Type 2 is the default if we're not told what type of diabetes someone has. But we do use the tachycardia code as our principal because that's the reason why she was admitted to the hospital. We don't have a definitive diagnosis for what was causing that, so we use the symptom of tachycardia as a principal. And this is just a reminder of which coding guideline I used. I use this example just to show you that depending on the description that's given to you in the diagnostic statement, if you're given just the diagnosis of a symptom of dysuria, that is an R code. But if it's described as a psychogenic dysuria, that's an F code, behavioral code. So always be sure you're reading your journal of epistaxis, where the epistaxis is a symptom, in this case of someone with hypertension. It's coded separately because it's not an integral component. Not everybody that has hypertension has nosebleeds. So we do code it as a symptom along with the hypertension. But if we were looking for the description of a hereditary epistaxis, then we would have a totally different code, I-78.0. Chronic fatigue syndrome I have here because it's such a, what would you say, a non-definitive diagnosis. It typically a syndrome by definition is several different things that are going on at the same time, and they're grouped together, and the doctors have decided that they're a syndrome. And in the case of chronic fatigue syndrome, the patient is complaining of several symptoms, and those symptoms group together into chronic fatigue syndrome. So I'm not sure that coding guideline is exactly right, but I chose it because I almost feel like chronic fatigue syndrome sometimes is what the doctor chooses when they can't find anything else to tie together someone's symptoms. Exercise 6, I'm showing the difference if you have information in your diagnostic statement telling you that the fever is due to a viral syndrome. You're going to code the viral syndrome, not the symptoms, because inherent to any viral syndrome, oftentimes fever, malaise, headaches, whatever. But the second line, the fever of unknown etiology and a headache, you're going to code both things as symptoms because it's not been identified if they are related back to a viral syndrome or they're just symptom codes because we don't know anything else more definitive to report. Here's a long one, but I wanted to walk through it with you. The patient was seen in the emergency department. She stated she was unrestrained in a vehicle that was involved in an accident 7 days ago. She denied any serious injuries but stated she has had a persistent headache over the last week. She also reported that while she has a positive PPD skin test, she does not have tuberculosis. Bacteria was seen in a urinalysis, however she's asymptomatic and I doubt she has a UTI. A CAT scan of her head showed no abnormalities. I suggest she follow up with her family doctor in 1 week and he or she will determine if additional workup is needed. I let you know in the note there at the bottom that bacteremia is when bacteria is present in the bloodstream after an insult, traumatic insult. It usually clears itself and it is not indicative of any kind of infection, but we do report it with an R code. So we have the headache, the positive PPD, and the bacteremia all reported as symptom codes in her case because there's nothing more definitive that we can offer. And here's an example of repeated falls, and there is a guideline that talks about repeated falls and a history of falling, and this is used quite a bit because in nursing homes it is not unusual for residents to fall, and I'm glad that there's codes that allow us to report that so that it can be tracked. In this case, the patient was admitted to the hospital from a community nursing home. He's fallen 4 times in as many days. Prior to this series of falls, he had fallen twice in the last 6 months. We will admit the patient to work up a few things and see if we can figure out what's going on. Initial labs were unremarkable. A CAT scan is pending. So we have nothing more definitive than the repeated falling and the history of falling. And the coding guideline tells us that we can use both codes when it's appropriate. The Glasgow Coma Scale is used when a patient has a head injury, and it helps the doctors to know what treatments to order, predicts how long they're going to be in a coma, and are they going to recover from this coma? What are the predictors? Typically, you see them reported by the EMTs who bring the patient to the hospital following an accident. So in this case, the patient sustained a traumatic brain injury when she was thrown through the windshield and was discovered hours after the accident. This is the initial encounter for this patient. She had a Glasgow Coma Scale score of 8 at admission as reported by the EMT that brought her to the ED. It is unknown how long she was unconscious. I feel there is a poor prognosis for this unfortunate young girl. So we code the brain injury. I've walked you through how we get those codes, and the Glasgow Coma Scale with a total score. In this case, her total score was 8. It falls within the range of 3 to 8. And when you look in your alphabetical index, you'll see the ranges there. The lower the score, the poorer the outcome. Because in the diagnostic statement we were told we don't know how long she was unconscious, we have to choose the loss of consciousness unspecified duration description for the 6th character, and the 7th character is A for our S06 code. Here we have a code for functional quadriplegia, and this distinction is made because if it were quadriplegia following a stroke or some kind of cerebrovascular insult, you could get a G code or an I code. But in this case, there's no other reason for this person's inability to move except for how debilitated she is. The patient was admitted from home following a visit from Adult Protective Services. It appears she has not been bathed recently, and she is very debilitating. She is exhibiting what I feel is functional quadriplegia. I believe she is not able to walk due to the debility. There is no evidence of any neurological insult. So we use this coding guideline where we have a documented diagnosis of functional quadriplegia, and we can therefore code the R53.2. And here is SIRS, or a systemic inflammatory response, SIRS. SIRS due to a non-infectious process. It is not uncommon to have a SIRS diagnosis because of an infection that's just become rampant through the whole body. This is an example of a patient having that systemic response, but it's non-infectious. The example we've been given is acute pancreatitis. So we're going to code the acute pancreatitis, and then we're going to code the syndrome of non-infectious origin, which is an R code. If there had been an organ dysfunction, we would be using R65.11. And I show the explanation and the coding guideline. As always, be mindful. I've tried to cover all the guidelines in Chapter 13 for symptoms and signs and ill-defined conditions, but there are always things that aren't covered in these PowerPoints. Please review them all whenever you're doing your homework and preparing for exams. Let me know if you have any questions, and I will talk to you soon. Have a good week.